Okay, so we're going to look at quality improvement kind of from two different realms, within the healthcare realm and then within the public health realm as well. So for healthcare, quality improvement consists of systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. Before we can measure quality, you really have to be able to define it, and that definition of quality is going to change depending on what realm you're talking about. So quality within healthcare is going to be different than quality within public health. Within healthcare, it can be defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And that is according to HRSA. Do you guys know who HRSA is? Health Resources and Services Administration.
You guys know who HRSA is?
Yes, they're just not talking because they never talk to me.
It was on their exam. I could see how many got.
All right, and so public health. Public health QI is the use of a deliberate and defined improvement process which is focused on activities that are responsive to community needs and improving population health. So again, their definition of quality is going to be a bit different. Their quality refers to a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality in services or processes which achieve equity and improve the health of the community. So, a lot more long-winded than the definition for quality of healthcare. But why is that? Why would the definition of quality for public health be so much more in-depth than that of healthcare? What is the difference between the two? Think about your populations. Specifically, the word populations.
Isn't healthcare more individualized and then public health more population-based, so we're going to get more of a broader population?
That is exactly correct, yes. And so that information comes from Nacho. Anybody know what Nacho is, besides the snack of cheese?
National Association
Of?
City and county.
Yes, health offices.
Gold star.
Okay, so first we're going to talk about quality improvement in healthcare. So the term population health is still kind of relatively new. It's been more prevalent in recent years with your shift in focus from quantity of care to a quality of care approach. So this should make you think of terms like triple aim, pay for performance, value-based purchasing. Quality is a path to population health improvements, has taken center stage as the nation sets a course of action for better care, better health, and lower costs. In 2010, the Commonwealth Fund study was conducted for quality in the U.S. healthcare system, ranked 6th when compared to 7 other countries. Good, bad?
Bad.
Bad, yeah. Anybody in here a Disney fan? Disney movies? Oh, yes! That got a very excited reaction. Okay, so you guys are familiar with Cinderella?
Yes.
Yes, okay. The whole mirror, mirror on the wall.
Who's the greatest of them all?
Who's the fairest of them all? Yes, greatest, whatever. So there was actually a follow-up report to the Commonwealth Fund study done in 2014 called Mirror, Mirror on the Wall. In that study, the U.S. ranked last out of 11 countries for achieving better health outcomes and last or near last in regards to access, efficiency, and equity. So who's the fairest of them all? Not the United States. We didn't do awesome. Our healthcare tiara is definitely askew on our little noggins. So kind of then comes in the ACA, right? With the passage of the ACA, we have these new quality incentives that are in place for healthcare. Tell me a little bit about the ACA quality incentives. What are they for? Don't everybody talk at once. Either.
To encourage doctors to focus more on the quality of care instead of quantity.
Yeah, Exactly. So the quality of care that they provide is directly commensurate to the reimbursement they receive. So just a little bit of history of quality in healthcare. In 1904, the Council on Medical Education Board was established and resulted in transformation of medical schools. Have you guys also heard of like CME units, continuing medical education units? Okay. So the CME recommended educational policies to the AMA. Who's the AMA?
American Medical Society
Okay.
Association.
Yes. To their House of Delegates. Collaborated with other key organizations in medical education. They support accreditation of medical education programs and gather and disseminate data about medical education products and services. Then in 1911, Ernest Codman, a Harvard medical surgeon, used metrics to evaluate the source of any medical problem by collecting demographic, diagnostic, treatment, and outcome data. So he had this ideology that every hospital should follow every patient that they treat. They need to do this long enough to determine whether or not the treatment has been successful, and then to inquire if it wasn't, why was it not successful? He didn't win any friends with this because he thought the system should also be used to evaluate surgeons and determine their promotions. So he didn't win any friends with his ideology. To err is human. I think you guys maybe read the executive summary of this. Okay, great. So in IOM's 1999 report, it said that avoidable medical errors resulted in 44,000 to 98,000 deaths per year. Anybody have any thoughts on those numbers?
That's a lot.
That is a lot, right? So roughly 45% of those deaths could have been avoided. We talked a little bit about avoidable injuries and deaths when we talked about health reform. Do you guys remember what any of those were? Think about hospitals. Something with hospitals. You go into the hospital, you get treated for something, you go home. So hospital-acquired infections, right? You go in for one thing, you get that treated, go home, you find out you have something else, have to go back to the hospital. Also in that report, it said over 1 million injuries. And just to provide a little bit of context on the injuries, so medication errors alone outpace workplace injuries. And you have to think about, when it comes to medication errors, this could be being prescribed the wrong medication, the wrong dose of a medication, and these are only the ones that were reported. So someone that had an adverse reaction when they realized the medication error as well. Healthcare was lagging compared to other high-risk industries. So what would be some high-risk industries?
Mining.
I'm sorry?
Mining.
Mining? Yep, what else? Railroad, air and space, logging, forestry, all of those, right?
Did you say fishing?
Yeah.
The deep sea fishing?
Oh, deadly as cat.
In 2008, annual costs of medical errors that harm patients amounted to $171 billion. That is not a small price tag by any means. When you think about these costs, there's one type of cost that I really want you to keep in mind, and that's opportunity costs. Have you guys talked about opportunity costs previously? Yes? No? I see a few heads nodding. Okay. So opportunity costs, if you have this $171 billion, that money is basically out the door, right? So you've lost that much in opportunity costs. Those funds cannot be used for any other purpose at this point. So causes of these errors. What do you think would be some causes of these medical errors?
Doctor's handwriting.
Sure, doctor's handwriting, so we've got some communication issues. What else?
Could it also
Charting.
be
Charting?
not shielding the patient when they receive their x-rays, for example?
Sure. Yeah, so not following protocols. And you have to think that these are kind of, there's microsystems that are part of this whole healthcare delivery system, right? So keeping all of those succinct is kind of difficult. What about cognitive bias affecting problem solving? So we both
I can
approach
see.
a problem. I think it should be done this way. You think it should be done another way. So you have to come to a resolution, and it may be a marriage of both of those. How often does new research come out in healthcare? Like almost on the daily, right? So that would be difficult to keep up with as well. Because all of that new research informs healthcare recommendations. Quality chasms. What is a chasm?
Space.
Right. So it's big space. So there's going to be a big difference, right? So we're going to be talking about big differences in quality. In 2001, the CDC declared the public health system as structurally weak in every area. That's almost painful to say, particularly being in public health, right? Also in 2001, there were terrorist attacks in New York City and DC. Congress allocated $3 billion over a 3-year period to strengthen public health agencies and infrastructure. So with all of these things, the World Trade Center, Pentagon, the subsequent anthrax attacks, all of that caused this surge in support for public health preparedness. Fast forward to 2011. Gaps still exist. The U.S. ranks #1 in terms of healthcare spending per capita, and by per capita we mean what?
Per person.
Right, gross domestic product. However, the nation ranked 39th for infant mortality, 43rd for adult female mortality, 42nd for adult male mortality, and 36th for life expectancy. Let's talk about spending a little bit. From 2015 to 2025, there's a projected spending growth in healthcare expenditures of 5.8%. 2014, the per capita healthcare cost was just over $9,000, and by 2016, it surpassed $10,000. That's a substantial amount of money. Look at things like your infant mortality and death of women during childbirth, particularly given the health infrastructure within the United States. Should we still be having this issue of infant mortality and these women dying during childbirth? Like we're a developed nation, right? And we're being compared to all of these other nations. Some of them are not developed, and we're doing worse than they are. We can't even keep our babies alive. A problem? Yes. So despite the amount that the United States spends on healthcare, we're continuing to see these emerging health challenges, including obesity, climate change, chronic disease epidemic. Obesity, how prevalent do you think childhood obesity is in this area?
50%.
So, national average right now I think is like 20.5%. Okay, I did my master's thesis on child and adolescent obesity in Carter County, Tennessee, so just over in Elizabethton. 42% is their childhood and adolescent obesity rate, so more than double the national average. Huge problem here. So what can be done about these emerging health challenges? What can we do to adapt to these challenges? This is where quality improvement really plays a role. Advances in quality improvement for healthcare. So with the Affordable Care Act, advent of accountable care organizations, the hospital readmission reduction program that we talked about during Reform Week, pay for performance, and the triple aim framework, all of these are really addressed at the quality of the nation's healthcare system to improve health outcomes while decreasing per capita costs in healthcare spending. Let's start off with the ACA. Most of this should sound very familiar to you from when we chatted last time. The ACA seeks to improve quality, access to care, and improvements in population health. The ACA was this longitudinal process, right? Aimed at the reformation of the healthcare system as a whole. The main objective was to have a healthcare system that provides nearly ubiquitous coverage, with the responsibility being shared between whom? Was it just the government's role, or was it employers, or was it individuals, or was it a combination of those? Right, so it's shared responsibility. The National Quality Strategy includes priorities to improve outcomes, patient care, payment policy, health data, reduce errors, and preventable admissions. So this was led by the Agency for Healthcare Research and Quality. It's under the HHS umbrella. So for payments, we're talking about incentives for your patient-centered care, your quality of care. Your health data is going to be referring to your electronic medical records to aid in care coordination. ACOs. We talked a lot about ACOs a few weeks ago, right? Someone tell me just a couple of things that you remember about accountable care organizations. I got nothing but time, so whenever someone feels like chatting. Don't make me start calling on people. Okay. Give me one thing about ACOs that you remember from last time we chatted. Is an ACO one person, or is it a group of people?
Group of people.
It's a group of people.
Yeah.
Does one person have the responsibility, or do they share responsibility, or do they have a board, or what?
Shared
Responsibility. Yes. So it's a network of doctors and hospitals that share financial and medical responsibility for providing coordinated care to patients. Why do you think it's important that they delineated financial responsibility in addition to medical responsibility?
So they don't like that. So it's like more balance between your medical care and like making sure they're paying or not overpaying or
Right.
something
So
like that.
if I only have medical responsibility, but I don't have any financial responsibility, if I make a medical mistake, am I going to be bothered by that much? No, because I'm not having to pay for it, right? So it's part of an accountability issue. They bring together primary care, specialists, hospitals, home health, and ensure that all of the parts work well together. So this is care coordination. They assume the risks and the benefits. So we talked about this a couple weeks ago, where they had these benchmarks, and if they met the benchmarks, say they spent less than they were allotted, then they get to keep the extra money. Yay for them. If they spend more money, they have to eat the cost. But there's a problem with this, right? Patients are in the habit of going to a bunch of different doctors. It's not a habit for them to go to one place and have this kind of one-stop shop. So it's really a change in patient culture as well in that mindset. So this aims to provide a more holistic approach to care, recognizing that one facet of healthcare they both directly or indirectly influence each other. Okay, hospital readmissions reduction program. We talked a lot about this. So every year, approximately 2.6 million seniors are readmitted within 30 days of discharge from the hospital. This equates to a cost to Medicare of approximately $26 billion. Why do you think there is this distinction of senior patients?
Because they're more likely to get sick and have to go to the hospital.
And who is their healthcare primarily funded by?
Medicare.
Medicare, right. And Medicare is funded by whom? The government. Have you guys talked about power of the purse at all? Have you heard that phrase? Okay, so it's really this interesting thing with federal government. They can basically persuade states to make improvements in the way they want to by way of power of the purse, because they're holding the little purse strings of money. Okay, so when the federal government makes these policies that impact Medicare and Medicaid, it really has a far-reaching impact. A hospital's not going to choose to only make improvements to just their Medicare population treatments, right? They're going to do it across the board. So the federal government is holding the purse strings and saying, okay, I want you to make these changes. They make those changes and it has an impact across the board as well. So it's a way that they can make changes and improve the whole system. So when CMS does innovation projects, remember when we talked about innovation projects through CMS? Yeah, something like that? A few head nods, okay. Or they work through bundled payments. It has a larger impact than just improving the care to the Medicare population. Factors leading to readmission within 30 days. Complications from treatments received during a hospital stay, so that's your hospital-acquired infections. Inadequate treatment, inadequate care coordination, and follow-up care in the community. Unexpected worsening of disease after discharge from the hospital. What are some other external factors that may play a role in hospital readmissions?
They can't. Well, you have follow-up care, but if they can't do like physical therapy or get hurt with physical therapy, then they have to go back.
Yep. What are some other ideas about external factors? Okay, I'm going to give you a scenario. I am 78. I've just been discharged from the hospital. I had a hip replacement. My husband is deceased. My children live in Washington State. And I have to go home now. What external factors in that scenario could cause a hospital readmission?
If you have no one to help you.
No social support, right? You don't have a caretaker at home to help you through. If I'm 70, whatever it was I said, years old, and I have no one at home, I've just had my hip replaced, I can't even stand up by myself. So what's the likelihood that I'm going to fall, injure myself, and end up back in the hospital? Okay? What about poor health literacy? What if I don't understand my condition? That plays a large role, so that's where patient education is so important. And what about inability to navigate the healthcare system? The healthcare system is large and complex, and that goes back to patient education as well. So the Hospital Readmissions Reduction Program was designed to improve quality of care and also care transitions from the hospital to home by incentivizing the reduction of hospital readmissions. Do you remember how they were incentivized?
Payment.
Yeah, by payment. So if they have a hospital readmission for that person, and remember that's not just at the same hospital, it can be at another hospital. If they have a hospital readmission for that patient within 30 days, their payment is drastically reduced. And again, this focuses on patients who are readmitted for select high cost or high volume conditions. So your COPD, hip, knee, joint replacements, coronary artery bypass surgery, things of that nature. Pay for for Performance, the hospital value-based purchasing program. So, taking all of these things into account, Medicare is now very keenly aware of how the quality of care that the hospital provides affects both patient outcome and healthcare expenditures. So the ACA implemented the pay for performance approach, affecting payment for inpatient stays in roughly 3,000 hospitals across the country. So Medicare adjusts a portion of their payments. How well they perform on each measure is compared to all hospitals, or how much they improve their own performance on each measure compared to their performance during a prior baseline period. So with this quality over quantity construct, the level of service, again, is directly commensurate to the reimbursement that they get provided for services. High quality services resulting in equitable reimbursement and vice versa. Triple AIM. Please tell me everybody in here has heard of the Triple AIM framework. I have to get a definitive yes from everybody about that one. 1, 2, 3. Everybody say yes.
Yes.
Thank you. Okay. So the Triple AIM framework is an approach to optimizing health system performance by doing these 3 things. Improving the patient's experience of care in terms of safety, quality, and satisfaction. Improving the health of populations. And reducing the per capita cost of health care. Why is this important? What is it about this trifecta of things that makes a difference? Think about the U.S. expenditures per capita on healthcare. Is it going up or going down, staying the same? It's constantly going up, right? So we have to do something to address this issue. But this is also a lofty endeavor. So you have to take a systemic approach. You have to identify your target populations, like seniors with the hospital readmissions reduction program. You have to look at your system aims and measures, make sure that they are clearly defined. You have to have an evaluation to adapt processes as the needs and conditions of the populations change. Are the population's needs going to be static? Or are they going to be fluid?
Fluid.
They're going to be fluid, right? They're ever changing because the population is ever changing. Okay, we are going to go to this website here. Maybe. Are you guys familiar with the hospitals here in the region? Vaguely familiar? Okay. All right, so this is Medicare.gov, and you can put in your zip code, and you can actually compare and contrast different hospitals within that location. Let's look at Johnson City Medical Center and Franklin Woods. Okay, just very first, overall rating.
Oh goodness.
Johnson City Medical Center, 2 out of 5 stars. Franklin Woods, 5 out of 5 stars. If you just looked at that, what would be your first impressions?
Johnson City Medical Center is terrible.
Right? I can see that. You're like, oh man, 2, that's bad. But you have to kind of keep some things in context as well. So what you're looking at, yes, you see a 2 and a 5, but it doesn't necessarily mean it's a bad hospital. So what types of care, if anybody knows, does Johnson City Medical Center offer?
Trauma.
They offer trauma care. Does Franklin Woods offer trauma care? No. So you're not really comparing apples to apples either when you're looking at this. Also, patient satisfaction is kind of a new construct, right? They haven't been doing all of these surveys and phone calls and such for a long time. And patient satisfaction can be very hard to measure. When I go out to eat somewhere, I think, oh, this is really good food. I don't think about going on and doing a review for them. It just doesn't occur to me. Now, when I go and have really horrible food and really horrible service and they completely piss me off, what am I gonna do? I'm gonna go write a horrible review about this place because they really made me mad. You have to keep that in mind as well. So, let's go down here. Oh, it's on the next tab. Survey of patient experiences, okay. And they have all of these different constructs that they measure. So, survey of patient experiences. This points to something that I was talking about earlier. Patients who strongly agree they understood their care when they left the hospital. Johnson City Medical Center is 49%, Franklin Woods is 60%. This is just my personal opinion. But when a patient does not understand their care when they leave the hospital, that is a problem. What is that going to potentially influence? Hospital readmissions, right? And so then that affects reimbursement rates and health outcomes, and it's like this snowball effect. Timely and effective care. So this is where you can actually go into all of the different, well, not all the different kinds of care. These are the ones that they measure currently, okay? Complications and deaths. So surgical complications, show graphs. Well, that was very anticlimactic. Anyway, you guys get the general idea. So, even though they have these patient satisfaction surveys on here, they have this overall rating, you have to make sure and keep in mind the context of how these surveys were administered, how patients maybe would have decided to complete the survey because they were mad or whatever. The services that are offered, there's a lot of different factors that go into this. You can't just really look at the scores and make a determination on that.
Are those based, like, how many stars you have, is that based off self-reporting? Like,
It
how
is.
do they gather the data?
Yeah, so this is off the patient satisfaction survey. They send them out to every patient that comes through the hospitals. They do it bimodally, so it's either on paper or they will send you a link if you've provided an email address in your patient intake. They can send it to you electronically as well.
Are hospitals required to participate in this?
I believe they are, yes. They don't necessarily have to do patient satisfaction, but they do have to do the rest of these measures, and these are part of their accreditation benchmarks that they have to document. We're actually going to talk about accreditation here in a little bit. Oh. Fast forward. Okay, how are we doing on time? Awesome. Okay. Does anybody have any questions before we kind of move on to quality improvement within the public health realm versus healthcare? Nope. Okay. Did quality improvement start in healthcare or start in public health?
Did it start on a factory line or something like that?
It did start on a factory line. It's most commonly believed that it was started on the factory line for Toyota. It's actually a misconception. It started with Ford, Henry Ford, and then it was adapted and expanded by Toyota, and they got all the credibility for it. So, just useless facts. So, when you see a good idea, if it's not trademarked or copyrighted, you're going to be like, ooh, that's a great idea. I should totally steal that. And in public health, that's what we do, right? So we see this good idea and man, that works really well. We can apply that in public health. So we do that. It's still, quality improvement is still somewhat new within public health. It's been within the last 10 years or so. Previously, it was called performance management or performance improvement management. And Dr. Beatty's work, she stepped out for just a second, but she's done a lot of work that was focusing on quality improvement and accreditation of health departments, and also coordination between public health and healthcare. And all of her work really has had policy implications. What is it about policy implications that can affect their work? If you have a change in healthcare policy or public health policy, how can that influence how that work is disseminated? Think back to Medicare and the federal government. So funding, right? If you have a change in policy, that can greatly affect funding moving forward. So one thing you have to know about QI work, though, it is resource intensive. It takes a lot of people to get quality improvement work done. And it doesn't necessarily have an immediate payoff. You know, you can say with hospitals, they're like, okay, we're going to do this new quality initiative. We're going to start offering this vaccine, and they see an almost immediate impact on their work, right? Because people are coming in, they're getting their vaccines. We can measure health outcomes. We have a decrease in flu. Awesome. If we're changing a process, how long is it going to take to see a result from a change in a process? That's going to be very time consuming. Okay. So just an overview of QI in public health. Many public health organizations use performance management efforts to track the work they produce and the results that they achieve. The public health leaders and managers face issues related to performance at many different levels of the public health system. So when we talk about performance improvement, performance management, quality improvement, it's across all levels. So it's at the individual level, it's at the organization level, it's at the system level. It goes across all facets. We talked about the definition of quality improvement in public health earlier, so I'm not going to go back through and read all of that. But the biggest difference is population level improvement, and its continuous ongoing efforts to achieve measurable improvements. So QI is also great for incremental changes to improve efficiency and effectiveness at its core. Have you guys seen this before? Yeah, should have. The performance management model. So this is from a program called Turning Point, and it has a lot of overlap with the tools, quality improvement tools that we're going to be talking about here in just a little bit. But the process is pretty similar across all of the tools. So you start with your performance standards. These are your benchmarks. These are your targets of excellence. This is what we want to achieve. And you're going to next go to your performance measurement. So this is where you create your indicators and your measures from those standards and develop a system to collect them. You're going to collect your data. Then you start the quality improvement process. You're going to use that data to make decisions to improve your policies, programs, and outcomes. You're going to compare your actual data versus what you wanted to achieve. So that you move on to your reporting of progress. Based on those findings, you're going to make decisions to improve these policies, programs, and outcomes. I know it's a box, but it's still a cyclic process. So you're going to be starting this and stopping this over and over and over again. That's the thing about quality improvement, is it really doesn't ever stop. Do you ever reach a point of perfection in quality? No, because we talked about how healthcare is fluid, right? It's not static. So as the needs change, the needs for your processes are going to change. So you're going to be doing this over and over again. Okay, we're going to go over this and then we're going to take a quick break. I know you guys have seen the 10 Essential Public Health Services. Yes? Many times, I'm sure. So in public health, we have these 10 essential services. This is our foundation of standards, right? Developed in 1994. It started out with these 3 core functions. We have assurance, assessment, and policy development. But those 3 are really broad. It would be difficult to develop outcome measures that are specific with just using those 3 broad terms. So then we have these 10 essential services. They are basically the operationalization of the 3 core functions. So now we have a standard to which we can create our metrics. So we go back here, our standards. This is our 10 essential services, and now we can move on to creating our metrics. But when the 10 essential services were really coming about, so to speak, there was this paradigm shift in public health. Public health had previously been seen as like you could package it in this pretty little box with health departments and government, and that's just where it went. But at this point, there was this shift where public health was seen as it's not really contained in that box anymore. It's applicable across all communities, across all organizations. So it's really interconnected with partners within your community. With the 10 essential services, this is basically saying that every community should be covered by a health department that provides all of these services. That came about in late 90s, early 2000s. Does anybody have any questions? Because we're going to get into some content-heavy stuff about accreditation here right after the break, so I just want to make sure you don't have any questions before we move forward. Okay, let me just pause this for a second. Let's take a 10-minute break. So be back at 5 till 2. And just as incentive to come back to class, I do have candy for you later. We're gonna play a game, so it's gonna be awesome. Are you guys familiar with accreditation just in general, what accreditation is for anything? Can someone tell me what accreditation is and what purpose it serves? Just in a general sense, not specific to public health or healthcare, just generally. What is it?
Like standards.
Right. So it's a set of standards.
Qualified once you meet those standards.
Yes. So basically, it is an assessment stating, yes, your organization meets these qualifications, and here it is written on paper. Here's your certificate. Good job, pat on the back. That's what accreditation is. We're obviously going to go into a lot more depth in that with public health. So, in 2007, the Public Health Accreditation Board was created. We lovingly call it FAB. It's the National Voluntary Accreditation Program that was launched in 2011. So, there was a multi-state learning collaborative where states that were already recording their measures and they were getting a seal of approval at the state level. So very much like the state innovation models that we talked about previously, where they did these models and they kind of tried things out to see how they went and then used that as a model to replicate. Very similar here. So there were states that were already doing this kind of accreditation thing without it being a formalized process. And they were the guinea pigs of sorts, and they were used as pilots to create the national accrediting body in 2011. So the goal of FAB is to ensure that 60% of the U.S. population is served by an accredited health department by 2015. So this applies to all health departments, whether it's at your local level, state, tribal, all of them can go up for accreditation. It's very similar to any accreditation program. Are you guys familiar with CEF that accredits public health? Yes, okay. So it's basically saying, here is what we expect you to be able to do. So the hardest part about going up for accreditation is providing your documentation, particularly for health departments. So you have to make sure that you document. When you have a meeting, somebody takes minutes. When you go to a community event, somebody does a report. There's lots and lots of data to collect. And accreditation is really important as well, because when you go through the process of accreditation, you're actually bettering your organization. For public health accreditation, there are actually 12 domains that are based on the 10 essential public health services. And these are standards and measures developed based on the NPHPS and state accreditation programs. So we had 10 for essential services of public health, 12 domains here. Those additional 2 domains are related to quality improvement and staffing or organizational characteristics. Going back to this goal of the 60% of the U.S. population is served by an accredited health department by 2015. What do you guys know about the Washington County Health Department? Is it accredited? Nope, it's not. The majority, unless I'm mistaken, the majority of health departments in Tennessee are not accredited, except for maybe some metro.
Yeah, so
Okay.
as you guys probably recall, this is where I geek out because I did my dissertation on accreditation. So I'll try not to bore you too much. But Tennessee, and did you talk about Baldridge yet?
Nope.
So Tennessee Department of Health, the commissioner, since it's centralized, the commissioner has a lot of influence on what happens at the local health departments and the regional health departments. And the current commissioner was more in favor of Baldridge over FAB accreditation. There are pros and cons for either one, but because of that, no, as they are called, rural health departments, non-metros, are seeking FAB accreditation. Knox County has sought it, and I believe Shelby is going for it, and possibly the Nashville. But this number of 60% of the U.S. population served, it's really interesting how they can get at this, because in certain states, are you going to talk about this?
You go right ahead, it's your class.
Okay. In certain states, like ours, that have a centralized system, but they can say the state health department went through it, and therefore all the people in that state are covered by accreditation. And really that's just one centralized health department instead of the regional or the local health department. So FAB has met this goal, but it's really been intentional in selecting and reaching out to partners in bigger communities, so larger metro areas and these centralized states.
And so if a health department is not accredited, again, that doesn't mean that they're a bad health department to go to or that the services they offer are not up to par. Sometimes it can just be that they may not value accreditation as much depending on their population, their location, the services that they offer. Like the smaller rural health departments, they typically offer more of your primary care services. So they're going to look very different than your larger metro health departments. Okay. Improving quality. The ACA authorizes HRSA and CDC to coordinate programs and funding to build incentives that promote interactions between public health agencies and community health centers. So again, this is all about improving care coordination. IOM report in 2011 or 12 talked about the integration of public health within the healthcare realm. separately, they've really existed in silos for a very long time. So meaning these people were over here, they did their thing, these people were over here, they did their thing, and there was very little crosstalk between the two. When they switched to the focus on quality and population health, then there was this shift for the care coordination. So we have these two major policy initiatives, and accreditation of health departments and not-for-profit hospitals. What is a not-for-profit hospital? How do they differ from a for-profit hospital?
Would non-for-profit hospitals not require people to pay if they can't?
Right. So basically what they would do is they would take a portion of what would have been their profit and they would cover any bad debt, so to speak. So these patients who come in and they're unable to pay their bills, it doesn't matter if you send them 100 bills once a week, it's not going to get paid. So they would take those funds and cover this. But under the ACA, there's this new policy initiative where these not-for-profit hospitals have to do a community needs assessment. What do you guys know about community needs assessments? Okay, so tell me a couple of things. One, why are community health needs assessments required? What are they meant to do?
You need to know the needs of the population you're serving, because that's gonna vary by location.
Yes. Okay, someone else tell me something about community needs assessments.
Proceed.
I'm sorry? Proceed?
Yeah.
Is that what I heard?
Yeah.
Okay, what else?
You have to evaluate the needs to know what you're going to implement.
Yes. And how often does this have to be done? Yes.
They can usually be done anywhere between like 5 to 3 years. I know Sullivan County does theirs every 3 years. So it's
Yes.
just kind of like up to the health department, I think.
Yes.
Like what time frame.
So what about the ACA influenced this policy for the need of a community health needs assessment for nonprofit hospitals? What happened that they thought this is a good thing to have in place? Okay, so with implementation of ACA, previously you have these uninsured or underinsured patients utilizing hospital services that are unable to pay. Okay, move forward. Now we have the ACA implemented. The number of people that are either underinsured or uninsured, has that gone up or decreased with implementation of ACA?
Decrease.
That has decreased. So the number of funds or amount of funds that hospitals previously had to write off, is that going to go up or go down?
Go down.
That's going to go down. Hence, community needs assessment. Okay? So after this needs assessment, what's kind of interesting is then the hospitals also have to develop a plan to address the identified areas of need. So it's not just, here's our needs assessment, filled that square, done, thank you, see you again in 5 years. They also have to develop these implementation plans about how they're going to address the needs of the community. 2011, the National Quality Strategy and National Prevention Strategy provides opportunities for public health and healthcare systems to work together. Healthy People 2020, Leading Health Indicators aligns public health and healthcare entities to produce synergy and accelerate rates of improvement. So, these bigger communities have hospitals, they have more money, they have more employees. There is kind of a power differential there, right? Between hospitals and health departments. Health departments are very familiar with assessment. That's their expertise, it's what they do. So it would make sense to have this collaboration between the two of them. How well do you think they communicate with each other? Not awesome. And a lot of it has to do with this power differential. I think as a whole, health departments are probably very eager to work with hospitals. They're excited about what they do, and I think they value collaboration. Again, that's just my 2 cents, take it or leave it. But collaboration would be mutually beneficial to both the health department and the hospital, as well as the populations they serve. I think a lot of research has been done around improving collaborations between the two as well. Okay, so this is where I might start talking really fast and get really high-pitched voice because I really love quality improvement. It's awesome. I do get excited about these things because I'm a nerd, but that's okay. So there's 2 different types of quality improvement. We have big QI and little QI. We talked a little bit about Baldrige a second ago, and we talked a lot about accreditation. We're going to go in more depth about Baldrige here in a minute. And then your little QI tools are Lean, 5S, Six Sigma, PDSA, fishbone diagrams, flowcharts, logic models, all kinds of these tools. So just by show of hands, who in here is a visual learner? Like, it helps if you can see something right in front of you. I am the exact same way. That is why I love this. I can see an entire process from start to finish, either in a linear model or I can see it in a flow chart, and that's just really helpful for me, particularly when I'm trying to identify gaps in a process or what works, what doesn't work. It's very helpful to have this this model. So Baldrige. Yes, it was named after a guy named Malcolm Baldrige. He was the 26th Secretary of Commerce. It was established by Congress in '87. It was created to identify and reorganize role model businesses, establish criteria for evaluating improvement efforts, and disseminate and share best practices. So one of the biggest takeaways from Baldrige is that it is not healthcare or public health specific. It applies to a whole host of organizations. And we're going to talk about some of those here in just a second. But this is the one that was actually started with Ford, and then it was adopted and expanded later by Toyota. So the scope was expanded to healthcare and educational organizations in 1999 and to nonprofit and government organizations in 2007. So they have these core values to deliver consistently positive customer experience, value and empower their workforce, think and act ethically and strategically. Let me see if we have time for this video. I think so. All right, so we're gonna watch this quick little video. It's right at 13 minutes and some change. But it's really informative about Baldrige. And I think you will garner a lot from it. Uh-oh, I don't have sound. Do you guys see that's Eastman? Mm-hmm. Okay. So these are the 7 categories or criteria for performance excellence. It's in leadership, strategic planning, customer focus, measurement analysis and knowledge, workforce focus, operations focus, and results. So across these categories, they answer these questions. Are your processes consistently effective? Not only do they have to be effective, they have to be consistently effective. Do your approaches address your organization's needs? Do they meet your mission, vision, goals, and objectives? How good are your results? There's nothing worse than bad data. Is your organization learning and improving? You guys heard that that saying, those who cannot remember the past are doomed to repeat it? Okay, same thing here. Your organization has to learn from the things that they identify and then make improvements. So these are some of the Tennessee Excellence Award winners. And I think Tennessee Department of Health should be on there as well. Yeah. Tennessee Department of Health should be on there as well. So there's this really, really cool story, and ever since Dr. Beatty told it to me, I have just been floored, and I think about it every time I drive by Powell's. So I want her to tell you this story about Powell's because it's just really fascinating, and I would have never even thought of this. And I swear, now every time you go to Powell's, you're going to watch for this.
Okay. I'm not gonna try to make you guys hungry here. I just actually added a link to an article from the Harvard Business Review about PALS. So they actually, it's an article, but they did a whole case study. So Harvard Business Review does these case studies. You can buy them. I didn't purchase it for you guys, but you can use them in your business, and they just are gaga over PALS at Harvard Business Review. So they write a lot of nice things about them. But they have a leadership excellence center through PALS, and they'll come in and talk with your business about excellence and quality improvement, and really how to improve your customer service. So a couple years ago, the faculty and staff in the college had a little workshop with them, because who are our customers? You guys, you're our customers. So we're learning about PALS, and they did not cater it, which was a bummer. But they were so committed to quality improvement that they have studied and they train their employees on how to lean forward out of the window that looks the most approachable. So they showed 2 pictures, and you looked at them, and both were of late teen females, very similar looking, what you think of as the people who work at a fast food restaurant. And one looked just slightly more inviting, and it was because of the way she leaned. Very slightly different, but they tested these. They have this very low turnover. Has anybody in here worked at PALS? No. They have very low turnover. They have really good opportunities for high school students. They give scholarships. But yeah, I was really just so fascinated that that's why they look so friendly. They have studied everything about the way they do their business. And you do not flip a burger or, drop the fries unless you've been trained and you've been evaluated. So you work with someone and you go through training, you get tested. If you don't pass, you're not in big trouble, but they want to ensure that you do it right. So when you eat your what did you say?
I said that's some Chick-fil-A type training.
Yeah. Yeah, those people are friendly too. But when you think of Chick-fil-A and you think of PALS, there is serious customer loyalty for those brands because you feel like they care about you. Have you ever been to like a McDonald's and been like, I didn't order this, but it's gonna take me 35 minutes to get this fixed. So I'm just gonna drive on, on my way on my trip. Another thing PALS does is when something isn't right, every person there has the right to make it right. So you don't have to wait for a manager to come refund you your $1.50. That's an important thing. And they time the time from the first window to the next, and they want to keep it at around, I think it's like less than 30 seconds from the time that you say this is what your order is till you get to the next window, which does not happen at Chick-fil-A. That does not.
Also, like I think they like train their employees how to count the money, so like your change is already like ready for you when you pull around like they always.
Yeah, so they have done process improvement and again, study these steps to ensure that they are doing everything to be as efficient and also customer focused. So I was just really fascinated because I come from a place that doesn't have a PALS, and when I moved here, it's like, what is this blue thing? And now I'm a loyal customer.
And I promise you, because I do this very thing whenever I go through PALS now, if you will notice, every single one of them lean the exact same way. Okay, so getting into the really exciting, fun stuff for me is your quality improvement tools. I did not test this link. Is this link still active for the Breakfast with the Expert recording?
No, they don't have to watch it.
Oh, no, I just didn't know if it was still active or not, if they wanted to watch it later.
It should be, yeah.
It is? Okay, cool.
Yes, it says lean, that Toyota thing.
Yeah,
That's what it says on YouTube.
yes, okay, perfect.
That was the name of the lecture.
Yes. So, lean is a customer-centric methodology used to continuously improve any process through the elimination of waste. So it's the cyclic process. You're going to start with identifying value, and that's the value of your process. So is this a good process or is it not a good process? If it's not a good process, we can get rid of it. Then you're going to map the value stream once you have identified this is a good process. The value stream is what works about the process, what doesn't work about the process, and then you're going to take out everything that's not working. When it says create flow, we're going to do rapid flow. But what do I mean by rapid flow other than fast? If we're going to do something quickly, we also want it to be what?
Efficient.
We want it to be efficient. So with create flow, it's going to be rapid, efficient flow. Establish pool. That means you're just going to be increasing your productivity. And seek perfection. We talked about this a little bit earlier. Can you perfect everything?
No.
No. So you're in a constant state of quality improvement, hence the cyclic process. You're basically learning to where you can be more effective, more productive with less resources. You're going to work smarter, not harder. Have any of you planned on taking Mr. Youngblood's quality course? Is that still going to be available in the new?
The quality course is offered over the summer, and I'm not sure if it's going to be offered over this summer.
Okay.
But it is becoming instead of a summer course, a full-fledged semester-long course because quality is a really important part of public health and healthcare administration, but also lots of other aspects of public health. And so the course will be bigger and better.
Okay. Awesome.
I'm not sure if it's this summer that will be, if it'll have one last summer.
Well, I would highly suggest that course. Mr. Youngblood is awesome. He definitely knows his quality stuff. You do an applied project, so you're actually applying some of these quality tools instead of just reading about them, and it's really, really useful information, so highly suggest that course. 5S, so you're gonna do sort, set, and order, shine, standardize, and sustain. Try to say that 5 times fast. This is a subset of your lean methodology. When you use it correctly, this is a set of processes that enables the user to clean and organize the space in such a manner that it makes it more effective and more productive, but you don't actually change the structure of the space. And by space, I mean literal space. We implemented this over at the regional office right up, I'm horrible with direction, somewhere in that direction, right over by the apartments back there. And so we went into this library slash kitchen slash junk room slash, I don't know, there was like all this crap just piled in this room. And it wasn't effective at all. So you would go in there if you needed to pull one of the books for something, for the Tennessee Annotated Code or whatever. You couldn't find anything because there was so much crap piled up everywhere. We didn't touch the kitchen part at all because that was kind of gross. But so we went down and we literally took every single book off the shelf and we sorted everything. We did it by type of book, so the topic that it covered, and then we sorted them alphabetically. So that was our set and order, and then shine. We literally cleaned the place top to bottom. We almost needed a hazmat suit. And then standardize. So you try to set these, once you have everything clean and organized, you don't want someone to come in and then just go back to the way that things were, and before you know it, 30 days and everything's piled up again, right? So you develop these new processes to keep things changed into this new order, and that goes into your sustaining. So while this methodology can be applied to a single project, it's also cyclic in nature because you're going to be constantly in the sustaining phase, and then as your needs change, you may have to start the process over again. 6 Sigma. This is also another subset of lean. It's a 5-step approach to process improvement. I realize that there are 7 bubbles there. I will explain that in just a second. It's a focus on improving the patient experience by making sure your processes consistently deliver the desired results. So the fundamental objective is the implementation of a measurement-based strategy that focuses on process improvement and variation reduction. So you want to not only implement this process, but you want to implement it the same every time. So the steps are define, measure, analyze, and then improve and control. With define, you're going to define your problem or whatever the issue is, the process that isn't working. Then measure. This is where you quantify the problem. This is where it's different from 5S. You're not just stating your problem, you're actually quantifying it. You're putting a number on it. Then you're going to identify the cause of the problem with your analysis. You're going to figure out why. Then this kind of little subset is modified design. After you identify the cause of the design, the cause of the problem, you're going to say, okay, because we now know the cause, do we need to maybe modify our approach? If you do, you go to the redesign phase and then back up to measure. If not, then you move right into the improvement stage. And this is where you implement and verify your solution. And then control is just maintaining the solution or sustaining the solution. PDSA or PDCA. Have you guys heard this before? You probably have. Yeah, Plan, Do, Study, Act, Plan, Do, Check, Act. Same thing, they're interchangeable. And you guys are actually going to do this here in a little bit. So, in a little mini exercise with M&Ms that you can't eat until the exercise is over. This is also known as the Deming cycle. So it is an iterative 4-stage problem-solving model used for improving a process or carrying out change. When using the PDSA cycle, it's important to include internal and external stakeholders. Why would we do that? Why would we need to include internal and external stakeholders?
It's gonna affect everything.
It's going to affect both of them. So when you guys had been working on your project, we said it was important to include members of the community, right? Same premise here. So you want it to be representative of what you're trying to achieve, right? They're going to be able to provide feedback about what works and what doesn't work. The stakeholders also define quality, so it makes sense to have them involved in the process whenever it's appropriate or feasible. When you're working with PDSA or PDCA, you're going to ask yourself 3 questions. What are we trying to accomplish? How will we know that change is an improvement? Is all change an improvement? No, definitely not. And what changes can we make that will result in improvement? So your first step is plan. You're going to identify and prioritize quality improvement opportunities. So this you're going to have, you're going to recruit a team. You're going to draft an aim statement. Describe your current context and process. Describe your problem and identify causes and alternatives. Next is the do phase. This is where you implement the improvement. You're going to collect and document the data, including problems, unexpected observations, lessons learned, and knowledge gained. This is where you can actually utilize some other smaller QI tools, and we're going to go over those here in a minute. But they're like flow sheets, check sheets, run charts, things like that. Fishbone diagrams. And then study check. This is where you're going to analyze your results. So was an improvement achieved? Did your plan result in an improvement? If it did, by how much, by how little? Was the action worth the investment? So your return on investment. Do you see any trends? Were there unintended side effects? And then your act phase. You're going to reflect on your plan and the outcomes. You're going to celebrate improvements and your lessons learned. If you decide that yes, we have identified this plan, it's going to work, then you're going to adopt that and you're going to standardize it. If you say, well, this worked, but this didn't, you're going to adapt your plan. You're going to change it and then repeat the PDSA process. If you decide it didn't work at all, you're going to abandon and start completely over. And again, this one is, well, they're all cyclical in nature. Yay, fishbone diagrams. Okay, so this is where we visual learners will get really excited about this whole thing. So fishbone diagrams are useful to focus on the problem details. So this one is about missed appointments within an OBGYN office. So this is your fish head here. So this is going to be your problem. We have a problem of missed appointments. And there are a variety of factors that could cause this problem. That's going to be the first box on all of your spines, are potential causes. Okay? So we have client perception, staff, transportation, appointment reminder phone call, weather, health issues, unforeseen circumstances, and location. Well, all of these causes also have causal factors, right? So what are those? Client perception, they feel as though the appointment is not important. Transportation, maybe there's not a bus route nearby and they don't have any other way for transportation. Appointment reminder phone call, they didn't get it because their phone number was changed or disconnected, or the message was taken by another person so they never got the message. So this is really useful in like brainstorming sessions to do one of these diagrams when you're trying to tackle a particular issue. That way you can see all of the potential avenues that you can work on and you can choose one of those for one of your quality improvement processes. Flowcharts. So this is more about organizational processes from start to finish. It's a visual representation of process steps. It helps because you can see how the whole process moves from start to finish. You can identify critical points or bottlenecks or problem areas in the process. You can see how the different steps in the process are related, and then identify the ideal flow of a process from start to finish, and design a new work process. So I went through this food truck phase, not only in eating, but they fascinated me as well for some odd reason. So this is actually about a food truck, and this is. So there was identification of these food trucks that had foodborne illnesses because they were either not licensed, so they weren't aware of protocols, or they didn't meet food safety regulations. So this orange one, and you can't see it really well, I'm sorry, but this orange one is identification of your health concern. So this is saying we have a food truck that has been identified where they had a foodborne illness, so we're going to go through this process now. Do a spot check, and there's initial compliance rate of 25%. So this is your process, your spot check, and then this was the outcome. After the spot check, we found that there was only 25% of the food trucks that were compliant. So then you go here, are they up to date on licensure? If yes, no other action is required and you can recheck as needed. If no, then they must cease operations until proper licensure is required. Same thing here for compliance with food safety regulations. And then you record your findings, determine rate of compliance of inspections, and something really fuzzy that I can't read on the screen. Or on my paper, so. But do you guys get the general idea of how the flow chart works? Yeah, okay.
Carrie, do you have a question?
Yeah, just what is the licensure required for food trucks? What is required for food trucks licensure?
Oh, they just have to have a license to practice.
But they don't get inspected by the health department, is that correct?
They do.
They do. Yes. Yeah, they do. And that's where the food safety regulations come in as well. But we found that there was a lot of food trucks that were practicing without even the license, much less food safety regulations in play. And when they go through the licensure process as well, they look at records of their inspections, and that plays into whether they get the license or not.
I see, okay.
All the ones on campus have licenses. Just put that out there.
Well, why is that optional? Because restaurants is not optional, so why is a food truck optional too? Why can they operate like that and not have, but a restaurant couldn't operate like that?
I'm sorry.
Operate without being inspected by the health department.
Oh no, they do have to be inspected by the health department.
All food trucks do?
They are supposed to be, yes.
Okay.
They are supposed to be.
But I'm sure it's harder to assure that because
Mhm.
food trucks, like,
Well, they're
they're mobile and
yeah. Yeah.
next thing you're in line with a food truck, ask them.
Yeah. Okay. Did that answer your question? Yeah. Okay, great. Logic model. This is one of my favorite tools to use just because this is that linear model where I can start here, go all the way to the end. I don't have to go on these little side tangents, and I can see the whole process start to finish, including my outcomes. So this is also called a line of sight model because you follow it from start to finish. And it refers to a worker or team member's ability to identify the work with the overall objectives of the organization in mind. So again, your mission, vision, goals, and objectives. And you can see the organization's goal at the end. So you have your outcomes here. It's a map or simple illustration of what you and your organization want to do. So again, back on the food vendors. So the situation is food truck vendors with lack of proper licensure and or adherence to food safety regulations. Our priorities is to do what? To increase vendor compliance and decrease possible foodborne illnesses. Inputs. This is really interesting. With your inputs, you have to make sure and include everything. It's not just like tangible resources like money or materials. It's also people's time, because that's really important, right? So we have these food safety specialists, environmental health specialists, your time and equipment. Your outputs. These are the things that you're going to do in your process. So conduct spot checks of food truck vendors, assess licensure status, work with vendors to promptly correct any violations, so on and so forth. And then you have your outcomes divided into short-term and your long-term outcomes. Your short-term is you're going to increase the awareness of importance of food safety. Long-term, we want to maintain a 100% rate of compliance. Any questions about all of the little QI tools that kind of can be fit into the bigger models? Okay. So just a few myths and truths about QI before we get into our PDSA QI game. QI is about weeding out the bad apples. The truth is QI is about processes, series of steps or actions performed to achieve a specific purpose. It's identifying what's not working about the process and fix it. If I don't achieve my goal, I failed. The truth is, when doing QI, there is no such thing as a failure. It's always good to know what doesn't work, as well as what does work. Because then, if you know it doesn't work, you can cross it off your list of possible solutions. And then we talked about this briefly, but the myth is that all change equals improvement. When in reality, it's all improvement equals change. Just because you make a change doesn't mean that it's going to be an improvement. And you also have to think about cost benefit, right? Even if it's a relatively good process, if the cost outweighs the benefit, you still have to chuck it. Okay, QI tools and resources. Feel free to go on and look at those anytime you would like. And now we're gonna play a game and eat some candy. Okay.
Should we take a break and let everybody?
Yes,
stretch?
it is. So 10 minutes, 3 o'clock, come back.
George, right here.